Assalamu alaikum, everyone. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fourth year medical student, and inshallah for today, we'll be going over again another OSPE review, inshallah. This time it will be renal, and like every other session that I've done already, this will be interactive. And I'm gonna be giving you guys pictures, showing you guys pictures, giving you guys cases. You guys tell me what the disease is or what the picture is, and then I'll give you high yield facts about the disease that you guys need to remember for your exam, inshallah. So let us begin. So the way I divided the session is going to be based on pathology, radiology, and micro. Okay. There are some clinical things that I did include that are high yield in terms of images or anything that has like identification. Okay, I included. So it'll be a long one, but inshallah, it'll include everything for your exam. So let's start. So the first thing is we got to understand what the normal kidney looks like, and I'm going to just explain it very quickly. So the first thing on the image on the left of the glomerulus on biopsy, for example, or histology, the first thing is this is the glomerulus, right? Okay, so in the glomerulus, you have the blood vessels, which are all of these. So these blood vessels are lined by endothelium. After the endothelium, you'll have the basement membrane and then the epithelium. So if we look into here, this is going to be where all the endothelium is going to be. The basement membrane would be here as well. Then another epithelium, which is going to be the visceral. Then a capsule between the visceral and parietal, which is going to be called what, guys? You guys tell me. What's this capsule called? Bowman's capsule. Good. So Bowman's capsule. Then the parietal epithelium, which is here. Then afterwards, obviously, the blood is going to go from the endothelium, basement membrane, epithelium, in the Bowman's capsule. Then it'll go through the proximal tubules, the loop of Henle, and then the distal tubules. The ones that are going to be closer to the glomerulus would be the proximal tubules. Anything further will be distal tubules, okay? So now, the most important thing out of all of this is understanding the electron microscopy. So the first thing is the endothelium. The key point into remembering that this is endothelium is you might see blood cells, or red blood cells. And I'll show you pictures later on that actually has them. Then you have the endothelium, which is this lining, basement membrane, and then these, the epithelium. This is going to be the visceral layer. These things right here is very important. These are the podocytes, okay? Now, key point out of all of this is that this whole lining has to be intact, these three layers. If you have, by any chance, disruption of the podocytes, this will cause charge issues, okay? So with charge issues, it's going to allow proteins to be filtered, meaning it causes nephrotic syndrome. Then you have other things such as antibodies binding to, for example, in the basement membrane or depositing under the epithelium or the endothelium, causing nephritic syndrome. So this is just the broad classification. So now, when we look into glomerular diseases, you have nephritic, nephrotic, right? Nephritic syndrome will have what in urine mostly? Blood. So hematuria. Nephritic syndrome, okay? So they will present with hematuria. So that's number one. Number two is they will have hypertension, for example, and then they have anything that's specific towards a disease that causes the nephritic syndrome. The next thing is nephrotic syndrome, which is because of proteins that's being filtered into the urine now. Can someone tell me what is the cutoff for urine to be in the urine? Good. So the cutoff for proteins to be in the urine is 3.5. Okay. If it's more than 3.5, we call it nephrotic syndrome. Less could be nephritic if there's hematuria. Okay. So this is the broad classification. Now we'll go into nephritic syndromes and then we'll go through each one and I'll give you tips on each one. So nephritic syndrome broadly is caused by either immune complexes or direct antibody binding to an antigen that's located in the glomerulus. So if we look into the first thing is immune complex deposition. So for example, in someone who has, I will give you guys a case and tell me what the disease that I'm thinking of. So for example, a child who had pharyngitis, throat infection, 2 weeks later had cola-colored urine. What is this disease? PIGN or PSGN, okay? Post-infectious glomerulonephritis or post-strep glomerulonephritis, okay? This is caused by an antibody binding to an antigen in the blood, and blood has to be filtered somewhere, and it gets filtered in the urine. So the first thing, it has to go through the blood vessel, the capillaries and the glomerulus, and it passes through these three layers that I've been talking about: the endothelium, basement membrane, and then the epithelium, which will have the podocytes. So these immune complexes, the first thing that will go through is the endothelium. So it may deposit right under the endothelium. So it can cause subendothelial deposits. If it progresses past that, which it might, which most likely it will cause subepithelial deposits. Okay? So that's why we have these deposits. Is because these antigen antibody complexes already formed in the blood. So they have to go to the kidney to get filtered. That's just because that's where all the blood will go to. So as it's getting filtered, it will deposit either subendothelially or subepithelially. Okay? So now this one is very important. Now here you have something called anti-GBM, which is anti-glomerular basement membrane. I'll give you the case later on, but for example, if someone has hematuria and has signs of acute kidney injury, okay, and basically this is a type 2 hypersensitivity reaction, which is basically antibodies directly binding to antigens in the kidney, which is going to be in the basement membrane. Now, when we're looking into the kidneys, we have three different things to look at. First one is light microscopy, which is like the histology, the normal one. Then we have electron microscopy, and then last one is immunofluorescence. For immune complex deposition, what pattern in the immunofluorescence will we see? Granular, because it's not going to be able, like this deposition is not going to be everywhere. It's going to be at some areas. So it's going to look granular. That's why it's granular. Now, how about for this one, anti-GBM? Linear pattern, good. Why is it linear? Because it's all these antibodies are going to bind directly to these antigens in the basement membrane. So it's going to be all over. And the basement membrane is just one line. Okay, so it's everywhere. Okay, don't worry too much about this last one. So this is the general pathophysiology of these nephritic syndromes. Okay, now we'll go into each one. Let's start by this one. Again, I'm going to use the same exact scenario. A child around, for example, 8 years of age had an upper respiratory tract infection, pharyngitis, or skin infection, impetigo. 2 weeks later, presents with hematuria. What's this disease? PIGN, good. Post-streptococcal glomerulonephritis or post-infectious. The whole pathophysiology is immune complex deposition, okay? So in light microscopy, what you'll find is a hypercellular glomerulus. So hypercellular, why? Because you have so many immune cells, which are most likely, for example, you can see neutrophils in some areas and other immune cells, such as this neutrophil right here. So anyways, so that's in light microscopy. What is this called in the electron microscopy? Is it subepi or subendothelial? Subepithelial hump, okay? How do we know this is epithelium? Is this the podocytes? That's how we know that this is the epithelium. So it's right below the epithelium, so this is subepithelial deposit or a subepithelial hump, okay? Now this one, what type of pattern do we see in immunofluorescence? Granular, okay, which is what they call starry sky appearance or lumpy bumpy appearance as well. Okay, so this is for PIGN. PIGN usually is self-limiting. You just supportive treatment for PIGN, and that's pretty much it. Very common and very high yield disease. Okay, let's move on to this one. For this one, I'm going to tell you this. An adult has had either pharyngitis or gastrointestinal infection presented with hematuria. What is this disease, guys? IgA nephropathy. Excellent. Good. So with IgA nephropathy, it's basically that the IgA that forms will deposit in the kidney. That's it. Okay. So you might have, for example, this thickening that's happening, fibrotic lesions that's happening in the kidney. Not that important. Most important thing is immunofluorescence. What type of antibody will you see in immunofluorescence? IgA. Okay, pretty simple for this one. So you'll see IgA deposition for IgA nephropathy. The case is going to be exactly as is. Okay, an adult, most likely an adult, will present with these symptoms. Okay, now there is a counterpart for IgA nephropathy that happens with children, which is what this one is. What is this disease, guys? Perfect. Good. This is Henoch-Schönlein purpura, HSP. Okay. HSP, same exact thing. It's IgA deposition. Now, HSP, very important sign that you'll see is this middle picture, which is what, guys? What is the sign? Purpura. Perfect. So this very characteristic palpable purpura. Okay. So you'll have skin findings, which is this one. And then you'll have renal findings post-infection. Okay. And the difference between post-streptococcal versus IgA nephropathy or HSP is HSP is more acute. So it's most likely going to be around like 5 to 8 days later, they'll present with these signs. For post-streptococcal, it's usually 2 to 3 weeks after the infection. Okay. Is this clear, guys? Good. So now, let's just say all of these, a few weeks later, you didn't treat them or anything, and they present with signs of acute renal failure. You do biopsy and you see this. What is this, guys? Crescents, perfect, or rapidly progressive glomerulonephritis, perfect. So for RPGN, rapidly progressive glomerulonephritis, you have crescent formation. Now, these crescents are formed by proliferation of what cells? Is it the visceral or parietal epithelium? Parietal epithelium, perfect, excellent, good. So the parietal epithelium. Number 2 is what's making up these crescents? What two substances are making up these crescents? Fibrin, good. What's the other one? Cell, macrophages, perfect, guys. So what's making up these crescents are number 1, fibrin deposition and macrophages, okay? Now these pictures are just showing you the steps of RPGN where you have mild, like it's starting to form these crescents, and you can see some of the crescents forming around here. And then it's much bigger now, and then now it's collapsing or engulfing the entire glomerulus, okay? So now, when you're looking into just the light microscopy, you just say this is crescent formation or this is RPGN. RPGN is divided further into 3 different types, right? How do we divide it? Through what modality? The causes. Immunofluorescence, good. So immunofluorescence, you have 3 different patterns that you might see. We'll go over them. What's this pattern? Tell me the pattern first, guys, and then go over granular. Perfect. So granular appearance is caused by what disease? That causes RPGN. PSGN, good, or PIGN, perfect. So post-infectious glomerulonephritis, if it's left untreated, and specifically if it happens in more adults, it can cause renal failure. IgA can cause this as well. HSP that we just went through can cause this as well, okay? This granular appearance. So that's it. So if it's left untreated, especially in adults, it can actually cause RPGN. And if you do immunofluorescence, you'll see this starry sky appearance, granular pattern on immunofluorescence, okay? So this is because of immune complex deposition, okay? Let's go to this one. Tell me the pattern first, guys. Linear pattern, perfect. Now, what is this disease? Anti-GBM. Anti-GBM, okay? Which is what we call good pasture syndrome. Now, good pasture is, there's two signs of good pasture that I need you guys to fully remember. Number one is in the kidney, which is what's like, what are they going to have in the kidneys or in the urine? Hematuria. And what are they going to have in the next, on the other organ, lungs? Hemoptysis. So they'll most likely complain it's going to be a middle-aged guy who presents with hemoptysis, coughing up blood, and hematuria. Okay. You do workup and everything, you find this linear pattern on immunofluorescence, you know that this is anti-GBM, which is also called good pasture syndrome. Okay. Very important disease to remember, guys, this linear pattern. Very high yield for your exam. Now this one. Tell me the pattern, guys, first. Perfect. Nothing. Okay. Barely there. What do we call nothing on immunofluorescence? Pauciimmune. Perfect. Good. So pauciimmune is caused by vasculitis. Okay. Specifically, there's one more high yield that has that has more of a correlation with pauciimmune glomerulonephritis, which is going to be C. ANCA Wegener's Wegener's granulomatosis. Okay, which is C. ANCA. Okay, causes vasculitis, can cause this one glomerulonephritis, specifically RPGN. Okay. So this is pauciimmune because we're barely seeing anything here. We can barely see anything. We call this pauciimmune. And this is caused by C. ANCA, which is Wegener's, for example, vasculitis. Okay. It can be caused also by P. ANCA, which is microscopic, or Churg-Strauss. Okay. So these are the other ones. Now, what is this, guys? Okay. This is membranoproliferative glomerulonephritis. Okay. So membranoproliferative glomerulonephritis is caused by mesangial proliferation. Okay. Now, this mesangial proliferation that happens, it will cause splitting of the basement membrane. Okay. So when you're staining the basement membrane, it's supposed to be like one straight line. Like, let's just say like this. It's one straight line. Okay, it's not split. But however, because of the mesangial proliferation that's happening, which is in between cells, it will start to split the basement membrane apart from each other. So that's what we call this appearance, which is tram track appearance. Okay, tram track appearance. High yield for MPGN. Now for MPGN itself, it's technically a mixed nephritic nephrotic syndrome. Okay, so it might present with hematuria, it might present with proteinuria. Most important keyword to remember out of all of this is this, which is going to be tram track appearance. Once you hear tram track appearance, okay, I know what this disease is. Okay, and whenever you hear proliferative, you think of, okay, mesangial proliferation that happens. Okay, so that's that. Now for membranoproliferative, you have deposition. Where is the deposition, guys? Subendo. And to answer your question, yes, it's mostly when you do silver staining. So it's subendothelial. And again, how do I tell that this is the endothelium? You can see RBCs right here. Okay, that's an easy way. And then how do we know this is epithelium? Podocytes. So that's how you can actually tell where you're looking at. This is the basement membrane, so it's above it. This is the endothelium. The humps or the deposition is below it, so subendothelium. Okay, that's how we know. This is like one of the few ones that actually causes subendothelial deposition. Okay, so, and just to mention, there are two types of depositions that can occur. So the first one is gonna be this one, which is subendothelium. The other one is type 2, which is this one. Where is the deposition that happens? Intramembranous. Good. So this one is intramembranous deposition, which is also what we call dense deposit disease. Okay, so it happens into the basement membrane. To answer your question, I believe, to my knowledge, I think both of them does cause it. The tram track appearance, but I could be wrong with this info. So double check on this before going to the exam. So that's that. Now we're done with these. Let's move on. What do you guys see in both the light microscopy and the immunofluorescence? Okay. So the answer I wanted is it looks sort of normal. Okay. Immunofluorescence, there's nothing. Okay. There's nothing like too significant I can see. On light microscopy, you might see some lipid deposition, but however, it's not specific for anything. Okay. The most important thing that you do here is what modality, guys? If it's not on light microscopy or immunofluorescence, there's nothing on it. You do electron microscopy. Electron microscopy will show you this. This is the podocytes. Here's the other side. What's the difference? Let me like show you another. They're merged together and they're also effaced. They're flat. Okay. If it's negative both on immunofluorescence and light microscopy, and it's only showing you effacement of foot processes, and I'll tell you another clue is it's a child with proteinuria. What is this disease? MCD, minimal change disease. Perfect, good. Now, minimal change disease is the most common cause of nephrotic syndrome in children, in pediatrics. Now, guys, how do I treat MCD? What drug do I give them? Steroids. Does it have excellent or poor response to steroid? Excellent. If this was an adult, will it have good or bad? Just a throwaway thing. Bad, okay? It won't respond as well. Children, most common cause, it can happen in adults, very rare. But mostly important thing you remember is a pediatric age group has something called selective proteinuria, meaning that it's only for albumin. Okay, once you see these two, okay, I'm gonna go towards nephrotic. And the most common cause of nephrotic syndrome in children will be minimal change disease. Okay. They'll mostly tell you in the scenario that on light microscopy, there are no findings. On immunofluorescence, it's normal. Electron microscopy shows effacement, instant MCD. Okay. Now, guys, for nephrotic syndrome, I just want to touch on a bit more on the symptoms and signs and symptoms. Other than proteinuria, what happens in the face and in the legs? Edema, okay? Very high yield sign of nephrotic syndrome in general is periorbital edema or puffy, okay, face, okay? Mostly around the eyes. Another thing is you might have hyperlipidemia, and you might have what's it called, coagulability, because you lose antithrombin 3 in the urine, and proteinuria, obviously, which can cause hypoalbuminuria, okay? So low albumin. So these are just the features of nephrotic syndrome. It's not specific for a specific one, but for MCD, they have selective proteinuria, and they have, for example, they might have periorbital edema, child, and everything else is negative except electron, MCD. Next one. What is this, guys? FSGS, focal segmental glomerulosclerosis. Okay. So what does focal mean? I want you guys to tell me before I tell you guys. When I say focal, what does it mean? Some glomeruli. Good. More specifically, as you said, mashallah, it's less than 50% of the glomeruli. Because when you're taking a biopsy, usually you're going to take multiple. You need to see multiple glomeruli because of this. Okay, this is exactly why we need it. It's because we need to see how much is affected. Now, when I say segmental, what do I mean? Part of the glomeruli. Perfect, good. So it's focal segmental, okay? Focal, you can see this glomerulus is not as affected, and then you see this glomerulus is affected. And then when you look into this glomerulus, a big portion of this glomerulus is affected. However, the rest of it is not. So this is what we call focal segmental. Now, guys, just to mention, or just to ask you guys about this, what demographic is most likely to have FSGS? Good, excellent. HIV, obese, Hispanic, African American. Perfect, good job. Now, what blood disease? Okay, excellent, perfect. Sickle cell disease, perfect. And then heroin users as well. Good job. Most important thing is, I think the most highlighted picture is either this one in the middle or this one, because this one is clearly showing you that segmental. But they have to bring this one so you can see that it's not as like affected, like not all glomeruli are affected. Okay, FSGS, good. Now, what do we see in FSGS? This is a poor image, not gonna lie, but in electron microscopy, what do we see? If you guys can tell me, then I know you understand. Effacement. What is this thing right here in the middle? This big dark thing, RBCs. So we can tell that this is the endothelium, this layer. This is the basement membrane I'm highlighting. And then this is the epithelium that should have the podocytes. Can I clearly tell that there are podocytes? No. So they're effaced. Okay, so it's effacement of the podocytes. To tell the difference between this and minimal changes, firstly, the age group, the risk factors, and then this one will have light microscopy findings, the other one doesn't. Okay, so that's just how you can tell the differences between them. Now, guys, how about this one? Collapsing, good, perfect. So this is collapsing glomerulopathy, okay? Now, in collapsing glomerulopathy, is the most important thing I need you guys to remember about this is what layer is proliferating here. Excellent, visceral epithelium. That's the only thing I think that's high yield about this that I need you guys to remember is it's instead of the rapidly progressive where it's crescents, that's the parietal epithelium that's proliferating. Here it's the visceral, okay, collapsing. That's the only major difference I need you guys to remember. Now, guys, this one is important. What is this disease? Excellent, good. Membranous, okay? So this is membranous nephropathy. Perfect. So membranous nephropathy, from the name, if I say membrane, I'm thinking of the basement membrane, okay? So what you might have is thickening of the basement membrane, or it affects the basement membrane. It looks very big, okay? Because obviously basement membrane thickening we'll get to later. So it's gonna affect it's gonna look like the basement membrane is thickened on light microscopy all over the glomerulus. That's number one you can look at. Here you can see some granular pattern, however, it's following the basement membrane. Okay, so it's not exactly linear. So it's granular, however, it's following the basement membrane. The most important finding is this. What do I call this? Firstly, it's subepithelial. Excellent. What's spike and dome appearance? Good. So this is the spike and dome appearance. This is the dome that's caused by the hump, and this is a spike. Okay? Spike and dome appearance. Or another way you can tell, this is the dome, and then there's a spike, dome, spike, however you want it. Okay? So it's subepithelial deposit causing spike and dome appearance. Now, there are two broad what's it called? Etiologies of membranous. Number one is primary membranous, and it's caused by antibodies. You don't need to worry about it, I think, too much. But just for the sake of completion, it's called antibodies towards phospholipase. Okay. That's the primary cause, which is not caused by secondary disease. The most important thing you guys need to remember is what's the secondary diseases that can cause this. Firstly, I want you guys to tell me, what are the infections that can cause this? Hepatitis, which ones? B and C. Perfect, good. Can you give me 2 drugs that can cause this? NSAIDs. If you can tell me the other one, that's amazing. Okay, you got, mashallah. Okay. Gold, I think, can cause it, but penicillamine, which is a chelator. Okay. Penicillamine can cause this. Other than that, I think that's the major things that you remember for membranous nephropathy. So yeah. Now for this, tell me what this disease is. For the stages of membranous, not gonna lie, I don't think it was that important in my opinion. It's just mostly you need to identify that this is membranous. But I don't think there are stages for membranous. Like if I remember. I could be wrong, but like I don't think it was that important. Anyways. Oh, I don't think it's that important. I'm not gonna lie. Yeah, I don't think it's most important thing is that it's the spike and dome subepithelial deposits. Okay, so this disease, as you guys mentioned, is SLE. The reason I put this, you're not going to ask to identify this just because of these 2 images, but I wanted to mention it to start the whole discussion for it because it's a big topic in renal. So there are 2 types of rashes that you can see here. This one is the butterfly rash, and this is the desmoid rash, okay, or scar, whatever. Anyways, SLE has so many manifestations. Skin, very common. GI, what's it called? The serosa, the pleural surfaces, the pericardium can affect it, and it can affect the kidneys. Now, there are 6 kidney diseases that are caused by SLE. The most important ones are the next 2, okay? The other ones, just know it by description, what they are, but the most important ones, like key ones, are the next 2, okay? Those are the most important things. Number 1 is this one. What is this one, guys? Stage 3. Excellent. Okay, so this one is focal proliferative glomerulonephritis. Here, again, focal, what do I mean by focal? I need to drill these terms into your heads, guys. Less than 50%. That's number 1. Here, part of the glomerulus is affected. We could have called it segmental, but anyways, the thing that's proliferating mesangium, but you have fibrin deposition all over here. The most important thing to remember is this is the stage 3. The most, I don't want to say most specific, but the thing that everyone tests you on is this next one. You make sure you go into the exam knowing this next picture very well for SLE. This one. Diffuse, stage 4. Good. So this is diffuse proliferative. Diffuse meaning it's going to affect more than 50% of glomeruli. Okay, that's the difference between diffuse versus focal. What do I call this appearance on light microscopy? Wire loop, okay, or capillary loop. Good. So it's just a loop that's forming around the capillary. That's all. That's the most important thing that you need to remember from diffuse proliferative glomerulonephritis. Other than that, sort of a granular appearance, not that important, not specific. The most important finding of diffuse proliferative glomerulonephritis is the wire loop appearance. This image, the middle, memorize, okay? This is very important for SLE. Okay? Are we good, guys? Okay. Now, before you guess what this disease is, I wanted to mention. Let's just say someone who... Okay, actually, yeah, you're gonna have to guess this first. Yeah. Okay, so this is diabetes. So diabetic patients, one of the most important things about diabetes is the renal findings. So in diabetes, you have microvascular changes and macrovascular changes that occurs. So for microvascular changes that can happen is due to non-enzymatic glycosylation of basement membranes. Okay, in this case, it's a glomerular basement membrane. Now, if you remember from CVP, and I gave you guys the arteriolosclerosis, you have two types, hyperplastic and what's the other one? There's hyperplastic, there's the other one that's caused by diabetes. Arteriolosclerosis, hyaline, okay? Hyaline. The reason why I'm telling you this is it's in stages. Okay, the first thing is that happens is non-enzymatic glycosylation of the basement membrane, which causes this basement membrane thickening, which is the number one thing you find. Okay? Basement membrane thickening. The next thing that happens is hyaline arteriolosclerosis. If you ignore that I told you that. The reason why I told you this is that blood supply will be limited to the kidneys. Now, the blood supply is going to be limited. So it's going to cause it to sclerose. Okay? When it sclerose, it causes these findings. What is this? It causes nodular glomerular sclerosis, which are fibrin, because of fibrin deposition. That's what sclerosing is, okay? Because of the fibrin. What are these nodules called? This is very important. KW lesion, Wilson lesions, okay? So again, diabetes is in stages, okay? You don't jump to this immediately. First one, non-enzymatic glycosylation. Number two is hyaline arteriosclerosis, what then causes this, okay? That's how it can cause these two different findings. First one is the basement membrane thickening. The second one is nodular glomerular sclerosis, which is these KW lesions, okay? That's for diabetes. Now, one of the earliest findings of renal involvement of diabetes is microalbuminuria, okay? Note this down, I think this is in clinical. Microalbuminuria. At this point, you start them on, for example, ACE inhibitors and so on, okay, to try to control the kidney and try to lessen the amount of damage that can happen, okay? So this is nodular glomerular sclerosis that happens with diabetes, okay? Now, one of the last causes of nephrotic, very simple, amyloidosis, okay? On light microscopy, it's a typical amyloid deposition that happens, which is this pink amorphous material that happens. You do, what staining is this, guys? What's it called? The middle picture? Congo red staining, which shows you what? What is this called? Apple green bifringence, okay? It basically just shows you the light color, okay? Now, amyloidosis, there's three types. There's primary, secondary, and then local, I think is what the third one was called. But anyways, primary amyloidosis is due to a primary disease causing amyloid production, for example, multiple myeloma, and the protein that's deposited is AL, okay? So amyloid AL. The one that's secondary is due to a chronic disease that happens. For example, I believe it's sarcoidosis that can cause it. There is a protein associated, I think it's AA, SAA, something like that. It's in the slides, guys, just look at it. The third one is, for example, amyloid beta that deposits in Alzheimer's, for example. Okay, so that's what amyloidosis is you have amyloid beta sheets that deposits into tissues. Three different types, primary, secondary, and then the local, I think is what it's called. Okay, in the kidney, you have amyloidosis due to any of the first two, for example, and it causes disappearance. What type of glomerular disease does it cause? Nephrotic syndrome. Okay, clear, guys, to this point? Okay, so the bunch of diseases that can cause RPGN is mostly nephritic diseases. Okay, nephritic syndromes. So first one is post-streptococcal, IgA nephropathy, Henoch-Schönlein purpura, HSP, vasculitis. So for example, C. ANCA and P. ANCA vasculitis. And then you can have as well as anti-GBM. Okay, anti-glomerular basement membrane, Goodpasture syndrome. Majority of these can cause RPGN. Good. Okay. Now we're done with glomerular diseases. All clear? Because this is the bulk of renal. You understood this? Majority of it is done. Okay. Now for this. What is, let's just say, I'm going to give you guys a case. Someone who has, let's just say he's going through a surgery and all of a sudden he has a massive hemorrhage. Bleeds. A day later, they saw that his creatinine is very high. What happened? What is this disease? Good. And by the way, for the timings, I know there's a difference between them. We'll get into that. ATN, okay, acute tubular necrosis. So acute tubular necrosis happens due to an insult that happens to the tubules, okay? This insult could be ischemic or could be toxin-induced, okay? So for ischemic, which is majority of the reason why we have ATN, affects two regions of the tubules. What are these two regions? Proximal convoluted tubule or proximal tubule in general, just go for proximal tubule, and then the ascending limb, okay? The ascending limb of the Henle loop, and the most importantly is the proximal convoluted tubule. Proximal convoluted tubule is mostly susceptible. It's the most susceptible to ischemic damage, okay? Now, when we look at these pictures, the one I have my cursor on, guys, what is this caused by? Ischemia or toxin? Ischemia. Why do you say ischemia? Many points. In other words, it's patchy. Okay, good. It's on and off. It's not a straight line of damage that occurs. Now with this, what are these blue parts of the tubules representing? Casts. Now, if you think of it like this, look, these areas of the tubules are not receiving blood. So they start dying, okay? When they start dying, you have sloughing off of the cells into the tubule, into the lumen. These cells are going to start to go down the tubule, will get stuck, and will cause these casts. Another reason for this cast is you have these proteins that gets produced by the kidneys continuously. When you have an ischemia, they will keep getting produced and they'll get stuck. Does anyone know what this protein is called? TAM horsefly protein. Good, excellent, good. So it just gets produced, gets stuck, and causes these casts, which are granular casts. This is high yield to remember, granular casts. Okay. Another one. This other picture is caused by what, guys? What's the insult in this picture? Toxins, good. So toxins are most likely drugs, stuff like that. Okay. That's causing this. Okay. And how do I know that this is toxins? Continuous. Good. Not patchy. Perfect. Now, for the clinical course of ATN, it's the same, regardless of if this is due to ischemia or due to toxin. It's exact same. There's 3 stages to ATN. What's the first stage called, guys? Initiation. Perfect. Second one, maintenance. Third one, recovery. Good. The first one is because of the inciting event, either ischemia or the toxin. The most important thing about the other two stages, maintenance. What's their urine output, low or high? Low. Okay. What's their creatinine, high or low? Blood creatinine. High. Okay. That's in maintenance. Later on, the tubular cells will start to recover and will start to overfunction. So what's the urine output? High. And what's the creatinine? Low. And you could say the same exact thing for blood urea nitrogen. Low for low for if it's recovery, high if it's in maintenance, and hypokalemia because you're filtering a lot. Okay, so this is what's dangerous about it. It's because it can cause electrolyte disturbances. Okay, and hypokalemia, all these hypokalemia, hypocalcemia, hypomagnesemia. Why is it fatal? Heart. Good. What specifically, guys? The heart? VFib. Good. VFib. Trissades, then VFib. Okay. That's what happens. Okay, that's why these electrolyte changes are very important. That's it for ATN. For these two images, very high yield. Just to solidify this info, is this. This is the area that's insulted. Okay. And then you have here that this is the proximal tubule, and you can see these yellow, or sorry, this pink material is the cast. Okay. Another thing is look at the tubules itself. Highly eosinophilic. Here you have highly basophilic. Basophilic because it's going through pycnosis. It's going through cell death, apoptosis, or necrosis, sorry. Here you have it as it's already dead. Okay? So that's why it's highly eosinophilic here, basophilic because the nucleus is starting to die. And then here in the middle of the lumen, you have these casts are forming. Okay, so that's acute tubular necrosis. Now, guys, we go into the cystic diseases of the kidney. What is this one called, guys? Good. Multicystic renal dysplasia. Okay, so multicystic renal dysplasia, it's not as high yield to remember what the disease is. It's very high yield to remember the images. Very high yield to remember the images. So in the images, how can I tell that this is multicystic? Can someone tell me, like, what's one thing? If I see, I know this is multicystic. Cartilage. Perfect. Excellent. If I see cartilage, which is in this image, this big thing, here, what this is showing, I know this is multicystic renal dysplasia. The kidneys itself, does it look like a kidney? No. And I saw also in the transcript that if the doctor were to show you a picture of the ovaries, everyone would believe it. Yeah, it actually just does not look like a kidney. But the most important thing to keep in mind is cartilage. You see the word cartilage, big kidneys, cystic, go with multicystic renal dysplasia. Cool? Good? Okay. Now the other one, very high yield. I'm gonna give you guys an age group just to help you out. Adult. Good. Autosomal dominant polycystic kidney disease. Good. So autosomal dominant polycystic kidney disease, I already told you, it's an adult. Okay. Is it usually unilateral or bilateral? Bilateral. Good. Now, the kidneys will look bilaterally enlarged and cystic from outside. It looks cystic from outside. Here, I think that you have infection over here and a stone over here as well from the image. But it's usually a lot of cysts, and it's bilateral, enlarged, cystic. Okay, that's what it's showing you over here as well. It's all over the cortex, the medulla. So now, for these patients, what other organ is involved? Liver, good. So you have liver cysts. What do these patients have a high risk of dying from? Perfect. Brain berry aneurysm. You need to remember this key factor. Now, I'm very sorry for this next question, but what is the protein that's mutated here? I need the perfect polycystin. PKD1, PKD2. I don't remember this, but tell me, PKD1 is which chromosome? 16, good. PKD2, 4, good. So again, PKD1, PKD2, PKD2, both encode for polycystin, which is what's affected here. PKD1 is in chromosome 16. That's the one you need to remember, 16. And then PKD2 is in chromosome 4. These patients will present with renal, bilateral renal enlargement with cysts, hypertension, hematuria possibly, hepatic cysts could be involved, and the highest risk of death for these patients are due to berry aneurysms. These are the key words that you need to look out for MCQ, SCQ, OSPE. Clear? And it's an adult. Tamam. Okay. Tell me what this one is, guys. Autosomal recessive PKD. Perfect, good. So autosomal recessive PKD, what age group? Kids, children, pediatric age group. Mostly diagnosed in utero when they're first born even. Now, can you tell me from gross morphology? These kidneys, they look very enlarged, right? Do they appear cystic? Do I see cysts on gross morphology here in this image? In this image? No, it's smooth. Okay, smooth. Now, answer this one important question. Which part of the kidney tubules is affected in autosomal recessive polycystic kidney disease? Okay. The collecting ducts, okay? The collecting ducts of the kidneys, which is mostly going to go from the cortex to the medulla, enlarges, okay? Which causes this disease? Autosomal recessive polycystic kidney disease. And here it replaces the cortex and medulla. Does it appear cystic on surface? No, it's smooth on the surface. When you do imaging, you can see all these cysts inside. Okay, how do I know this is our autosomal recessive polycystic kidney disease? A child, or even younger, newborn, in utero, bilateral, enlarged, has signs of, for example, poor renal output in children that causes something called, it basically causes less amniotic fluid, so it compresses the baby. Okay, that's how it presents when the baby is born. Okay, I don't think you need to remember that, but that's just a sign. Okay, they're both bilateral. However, the age group is what tells you apart. Okay, histology is just you have these dilated ducts that's replacing both the cortex and the medulla. Okay, so it's replacing both of them. Here you can see cysts all over, but the surface is smooth. Okay, mostly in pediatrics, mostly in children, in like newborns, and usually they are compressed because they don't have that much amniotic fluid, because what's producing the amniotic fluid? The kidneys when they're urinating. So these kidneys are not functional anymore, so they don't have amniotic fluid. The amount of space in the pregnant wound is less, so they get squished. Okay, this is called oligohydramnios. Okay, now can you tell me, guys, which is more high yield, is what protein is affected? Fibrocystin, good. That's the most important thing to remember. And was there a gene? Six, okay. Anyways, fibrocystin is the most important thing to remember, and it's in children, okay? That's the two broad ways you differentiate them apart. Do you guys need me to repeat any of that again? All good? Okay. And the ultrasound, yeah, it is very important. You can see multiple cysts and these hyperechoic lesions, okay? But I don't think it's as important. Mostly it's CT finding. Okay. I will go over radiology. Don't worry. Okay. So next one. These ones aren't as high yield, but it's important just remember key terms about these. Medullary sponge disease. Where are all the cysts located? One word, it's in the name. The medulla. Okay. So it's located only in the medulla. So that's the important thing. In the CT scan, this is the cortex out here, and then inside is the medulla. You can see like these spaces that's happening in the medulla. This is all the cysts that are forming. So this is medullary sponge disease. Most important thing to remember, sponge kidney. Most important thing to remember is just the images for this. It might come in the MCQ just as cysts located in the medulla alone. Okay, that's just a key term that they might give you in MCQ if it comes. Okay, most important ones for MCQ, OSPE, everything is the last two that we covered. Some recessive, some don't. Very important. How about this one, guys? Good. This is medullary cystic kidney. Perfect. Okay, this is medullary cystic kidney. The way to remember, it's again not as important. There is genetic factors involved in medullary cystic kidney. Go over it just to know because it's kind of low yield, but go over it for your MCQ. Okay. But for OSPE purposes, if you want to identify this, the key term to look out for is it's in the cortico-medullary junction. That's a key term to look out for. Cortico-medullary junction. Okay. Again, if it's in the medulla and multiple cysts, like small cysts, you can say this is medullary sponge disease. If they say few cysts that's located in the cortical medullary junction, I'd go for medullary cystic kidney. Clear? Okay. Another thing is that there are genetic factors involved in this, and there's like two diseases on top of each other. Like there's a slide, go over it. Okay. Again, it's not as high yield, but you never know what you can get in the exam. Okay. But in OSPE, I don't think it will come. This one, let's just say someone had dialysis for a very long time, then had this. What did you have? Dialysis associated. If this comes, I'll give you the history. Guy has chronic kidney failure, is on dialysis. On imaging, bilateral or unilateral enlarged kidney. Okay, dialysis associated. That's it. It'll give it to you in the disease, in the case itself. Okay. This one is kind of important. What is this one called? Simple cyst. Now, the most important thing about the simple cyst is its classifications, which we'll do in radiology. Okay, when we get to that radiology section, it's very high yield to remember. How do we classify these cysts? How do we know this is a simple cyst, benign cyst, versus a malignant cyst? Okay, on gross, you can only just tell this is a simple cyst, which is just one thing. Okay. We're done with the kidneys except for the tumors later on. Any questions? Okay. Now let's just say for this, let's go. Okay. Let's say someone had a kidney stone, and proximal to the kidney stone, there is obviously urine that's stagnated there. Over time, you have chronic inflammation, whatever has this. What is this called? Urethritis cystica, okay? In the ureters, if you have, for example, long-standing inflammation that's happening, and basically you have inflammation, resolves, comes back again, resolves, comes back again, it forms these pseudo follicles that present as urethritis cystica, okay? Very important, remember the image, guys. Remember this image very, very well, okay? Urethritis cystica. Now, what organ am I looking at? Bladder, good. Now, the most important thing about the bladder right now is I want you guys to tell me what is the lining epithelium of the bladder? Urothelium. Good. Okay. Which is also, what's another name for it? Transition epithelium. Perfect. Good. Now, what are these called? Bronze. Perfect. Good. Bronze, are they benign lesions or metaplastic? Benign. Good. They are basically a reaction due to inflammation, infection, something. Okay. Now, over time, these nests will start to go deeper into the bladder to form this. So okay, this is just the von Buns next, is it's going to start to go into the urinary bladder muscle layers. Okay. So when that happens, what do I call this? When it starts to go and form cysts due to inflammation, due to infection, long-standing infection. We'll get to it later. Okay. Don't worry. Keep this in mind because I'm going to ask you this again. Let's go to here. Now, tumors of the bladder. I should have actually changed the arrangement of these slides because I just put it based on the lecture. But anyways, so when we look into the tumors of the bladder, what are the three types of bladder cancers that we can get? Number one is, what's the lining of the bladder? Urothelial, most common, or transitional. Number two is, let's just say someone had chronic schistosoma infection. What can they have? Squamous cell carcinoma. Perfect, good. Number three is because of this. What is this? Firstly, what is what is the image showing you? Urachal what? Cyst. Most important thing is you remember urachal cyst. Okay. So the urachus connects the dome of the bladder to the umbilicus. Okay. That's the urachus. Now the urachus will obliterate to form, if I believe, the medial umbilical ligament, I believe. If not, it doesn't matter, ignore it. So anyways, it'll form a ligament. Now, if it doesn't form this ligament, you will have something called a patent urachus, or you have something called a urachal cyst. Now, this urachal cyst can cause a cancer. What type of cancer can this cause? Adenocarcinoma. Perfect, good. What other congenital bladder malformation can cause adenocarcinoma? Bladder exstrophy, perfect. When the bladder is outside of the body, it can cause exstrophy. Most high yield thing to remember is this. This and exstrophy can cause adenoma. Here you have villus adenoma, which is these finger-like projections. And because it's a gland, so we can call it an adenoma, okay? So villus adenoma, most high yield thing to remember is urachal cyst can cause villus adenoma. Exstrophy can cause villus adenoma that can cause later on adenocarcinoma. Okay. Mostly this will be located at the dome of the bladder. Why? Because it's nearest to the cyst. Okay, makes sense. So that's that. Now we're gonna go back to what I was talking about. Now, if this von Braun's nest goes into the bladder, causes these cysts, what do I call them? What do I call this condition? Cystitis cystica. Okay. Cystitis, why? Because it's a bladder. That's what it's called. Cystica is it's forming these cysts now in the walls because the von Braun's nest goes into the bladder and forms a cyst. Like it's still benign. It's fine. Okay. Now these von Braun nests is due to an infection. Most likely organisms are what, guys? Two organisms that can cause this. Think of cystitis, guys. Not schistosoma. Schistosoma, as I said, can cause squamous carcinoma. Here, it can cause later on cancer. That's perfect, good. E. coli and Proteus. Remember these two can cause cystitis cystica. Okay. Now, if this cystitis cystica causes glands to form, what do I call this? If it forms glands, cystitis cystica glandularis. Okay. Remember these images, guys, because out of all the bladder things to get tested, this is the most like the benign stuff that happens. This is the most important thing. Okay. Cystitis cystica due to von Braun nest, which is usually benign, it's normal, goes in. This is what the glands. Why? Because these are mucus secreting cells, these clear cells. Okay. That's why I can call this a gland. Okay. This one, it sort of looks like it as well, but the most important thing, you'll get one of the images. You're not going to get all of them. But the main idea is this von Braun nest goes into the bladder wall, forms a cyst-like structure, then forms a gland. That's it. That's the main idea due to an infection, inflammation, something like that. Okay. Most two important organisms to remember, guys, E. coli and Proteus. Good. It is, but this is more clear of a gland. Yes, it is, but Malacca is more specific for them. Okay. Yeah. Which is what is this? Malacoplakia. Okay. So this is malacoplakia due to cystitis cystica. This is the more detailed finding that you can see. These are what type of cells are these? There's a name to this. MG bodies. Good, perfect. So these are the MG bodies due to malacoplakia. Again, Proteus and E. coli are the most high yield things to remember about cystitis cystica. Sorry for the background noise if you hear anything. Okay, we're good with the non-neoplastic bladder stuff. Yeah, it's steps. Okay, that happens. Firstly, you have I hate this name, von Braun's nests that starts to form. They're benign due to infection. Later on, will go and involute into the bladder wall, forms this cystitis cystica. Then over time, it'll form these glands. So it's an advancement that happens. Okay, this is just one specific finding. Yes. Yeah. No. Can someone tell me what organ am I looking at? Testes, good. Now, what are these called? Like the big structure. One of these. Seminiferous tubules. What are lining these seminiferous? Sure. Sorry, guys. I'm not too sure about this, but the idea that I got out of it, or the way I studied it, is that it could because of some macrophage thing that they have, defective macrophages that they have these findings, but I'm not too sure. Okay. I took it as a specific finding. That's it. Okay. So anyways, these are seminiferous tubules. What's lining them? Sertoli cells. Okay, lining these. Most important thing, Sertoli cells. Around them are interstitial cells, which are, what's the most important interstitial cell you look into? Leydig cells. Okay, so these are normal testes. Now, let's go into a few important facts before we go into the pictures. Now, when we're talking about testes, most important thing to remember is tumors. Okay, tumors. Now, obviously, you have testicular torsion, you have varicocele, you have hydrocele, all these things that are more gross pathology. In OSPE, you need to know the differences between these tumors. Now, going back, what are these tumors in men, in testes, formed from? Germ cells, mostly. You have other non-germ cell tumors, which are Sertoli cell or Leydig. Do you need to remember them in your block? No. Forget that they exist. The most important thing are germ cells. We further classify it into two types, seminoma and non-seminoma. Okay, that's a classification. In testicular tumors, you need to remember the markers, very important markers. Number two, specifics about if it's painless or painful. Majority of tumors are painless. There's one that's very painful. And you need to remember the key histology feature. Three things, okay? Now, the risk factor for testicular tumors can happen sporadic, but however, if the testes were undescendant, it can cause it. So what do I call undescendant testes? Cryptorchidism. Good. Another thing is you have, for example, heat, radiation can cause it as well. So heat, radiation, cryptorchidism can cause this to the testes. What's the first thing you see? The testes are damaged. So what do I call this? Or what's happening here? Atrophy, okay, of the testes. That's number one, atrophy testes. You need to remember anything detailed about this? It's caused by cryptorchidism, because of high heat, radiation, something that can cause atrophy of the testes, okay? There is also syndromes that can cause these tumors, such as Klinefelter syndrome, okay? Anyways, so that's that. Now, what am I looking at, guys? Now that I gave you that information, like how to think of it. IGCN. IGCN stands for intratubular germ cell neoplasia. Now, IGCN, does it invade the basement membrane? No. How do I know from here? Is look, you stained it with, I'm not gonna, like, the stain is not as important, but the most important thing, because it differs based on the tumor, is the fact that it does not cross the basement membrane. Okay, so that's why we call it IGCN. So now we go into, okay, we know that this is IGCN. Then we classify germ cell tumors. We classify seminoma and non-seminoma. Let's start with the first one that we get, which is this one, guys. What is this tumor? Seminoma. Good. Okay. Now, seminoma. Let's go one by one. Now, is it painless or painful? Painless. What's the color of the mass? White, or another way, yellow. Okay, white to yellow mass. Okay. Painless. What's the marker for seminoma? HCG could be, but there's one very specific one. PLAP. Good. Okay. PLAP. Specific for seminoma. Okay. It could not, like, it's not highly sensitive, meaning that it's not always that's going to be high. However, it's just a tumor marker. Just memorize PLAP for seminoma. Okay. You don't really need to fully know. Stand for, I have no idea, not gonna lie. Again, just something memorize and move on. Okay, so that's seminoma. Now for the histology. Which part of the testes is affected? One or two? Two. Okay, you can clearly tell. You can see here that the seminiferous tubules is a bit, it's there. It's normal. It looks okay. It looks probably there's some stuff that's happening, which is IGCN. Excellent. Here, it's invading the basement membrane. You can see all these dark cells. That's not supposed to be in the interstitium. Okay, that's why I can tell that 2 is a seminoma. 1 is most likely IGCN. Okay. Now, what's the histologic feature? What do I call this appearance? Fried egg appearance. Good. Fried egg appearance, once you hear it, buzzword for seminoma. Okay? Buzzword for seminoma. Again, painless mass. That's what's scary about it. However, the prognosis is good, usually. Painless mass. Tumor marker is PLAP, which someone already said it in chat, which is excellent. It's called placental alkaline phosphatase. Good. It is radiosensitive, response to chemotherapy. And one important high yield, guys. Do I take a biopsy from the sample if I see it? Yes or no? Never. Perfect. Why? Seeding of the tumor. Good. Excellent. That's a very important high yield. Okay. And then lastly, it's a white mass, homogeneous mass. Histology shows fried egg appearance. Good with seminoma? You do have syncytial trophoblasts. That's why you have, yeah, exactly. This is more pronounced in another tumor. That syncytial trophoblasts, what do they produce? If you guys know, beta HCG. That's why you might have them. You might not. It's not as specific for this. It's plus minus. Like you might have HCG that's high in here. It might not be high. Okay. The tumor marker that's more specific is PLAP. Okay. Good. This one, guys. Embryonal carcinoma. Good. Okay. Now, embryonal carcinoma, most important thing to remember, if you get this buzzword, you know what this is. Is it painless or painful? Painful. Yeah, it's painful. So embryonal carcinoma is painful. That's a buzzword in the key term. Okay, that's the buzzword. The rest are all painless. That's the most important information is a lot, guys. Just memorize or understand these key terms. Why is it painful? It's large hemorrhagic blood. It's bleeding, bleeding, bleeding. Okay, and that's highly because of the amount of bleeding. It's highly proliferative. Goes through a necrosis, dying cells, pain. Okay, and that's why you have this. Histology features, it's just very, it can produce glands, however, it's not apparent in this image. It's very, it just looks disgusting, honestly. Bad tumor, okay? So that's embryonal carcinoma. Most important thing to remember, it's painful. That's a buzzword. Next one. This one is important to remember everything about this. Yolk sac tumor, good. What's another name for yolk sac tumor? Endodermal sinus tumor, good. So, yolk sac tumor. Yolk sac tumor, or endodermal sinus tumor. Most important two things is what's the marker? Most specific marker, alpha fetoprotein. Okay, it can be positive other things. However, if you see these two findings, alpha fetoprotein plus this finding on histology, which is so specific. What's this finding called? Schiller-Duval bodies, which look like what? Glomerulus, like good. So it's glomeruloid-like feature. Okay. Yolk sac, again, alpha fetoprotein is high, and you have this Schiller-Duval body, which looks like a glomerulus. Is it painful or painless, guys? Painless. Again, only painful one is embryonal carcinoma. Good. This one, guys. Choriocarcinoma. Perfect. Good. Choriocarcinoma, painful or painless? Painless. Good. Now, chorio has two cells syncytial trophoblast and cyto. This big cell is what, guys? Is it syncytio or cyto? Syncytio, good. Or syncytio, whatever way you pronounce it. The small cells are what? Cyto. What's the marker for this most important marker because of the syncytial trophoblast? HCG. You see HCG is high. You see painless mass, very high HCG, abundance of syncytial trophoblasts, cytotrophoblasts. No, this is choriocarcinoma. This one loves to metastasize, I believe, and it metastasizes to the lungs. That's an important area of metastasis. Okay, it happens sporadically. Later on, inshallah, when you come to repro, I'll tell you the female side of this one. Okay. This one, it is very hemorrhagic, but I think it's just not as proliferative. Okay. That's why. Buzzword is painful. There's some stuff, like, not gonna lie, there's some stuff. It's not as like, it's not explained. It's a fact. Okay. Okay. Now this one, guys. This one is kind of high yield. All of these tumors, the previous one, specifically for the pictures, this one and the yolk sac tumor are the most important. This one is teratoma. Okay. Teratoma in men is very bad. Okay, it's mostly malignant if it's from the testes. Okay, it's most likely immature teratoma, and it's not that great. Okay, now teratoma is because you have, for example, it's a mix, exactly, it's a big mix of the germ cell layers. You have endodermal, mesodermal, and so on, and ectodermal. So you have, for example, cartilage, with teeth, with epithelial cells, glands, and then, for example, striations. Okay, hair as well, very important. Important image is this one over here, which is cartilage. And then you have here striations. Are these cells supposed to be next to each other like this? No, teratoma. Okay, this is important to tell from picture. This image specifically, yeah, I think so. But HSG is not as specific for these. It's not specific for majority of them except one, which is this one, choreo, because of the syncytial trophoblast. Okay, that's the one it's very specific for. The rest of them could have it plus minus. Okay, teratoma, most important thing, mixture of the germ cells, germ cell layers. So you have endodermal, mesodermal, ectodermal. Okay, we're done with the testicular tumors. Any questions from this section? The most important thing, know these specific details because there's so much information about them. So know these specific details. We went over the risk factor and know the markers. Okay. And the histology features. What organ am I looking at, guys? Prostate, good. Okay. This is the normal prostate. How many layers of cells do I see in the epithelium? 2. Okay, most important, 2. The basal cells have to be there, and then this is the second one. Does anyone know what this one is called? This thingy? Just a throwaway. No. These are basically the prostatic secretion. That's how you know that you're in the prostate. Okay. This is the corpora amylacia. Okay. These are the prostatic secretions that are accumulating. That's how you know you're in the prostate. You need to remember that? No, ignore it. Anyways, now you have the stroma. Okay. So you have striations because you have the muscles that can happen here and so on. Okay. Now, the most important thing in this is the glands and the stroma. So now let's just go for a case. Here, you have a male who presented to you, let's just say a 50 to 60-year-old male presented to you with a weak urine stream, with dribbling, complains that there's still urine that's still like he still feels a lot of urine after even voiding. What's the disease? Most likely is BPH. Okay. Benign prostatic hyperplasia or nodular prostatic hyperplasia. It's it's hyperplasia of the glands. You can see increased number of glands and stroma, which is in between these glands. Okay, both of them. How many layers of cells do you still see here? 2. It still remains as 2. I don't know why there are balloons. Anyways, which zone of the prostate is affected? The central zone or the transurethral or transitional zone, periurethral, whatever. That's why it causes the obstructive symptoms. Okay, that happens with urination. Okay, is this a pre-cancerous lesion, guys? No, good. What are the 2 drugs I might give in this case? Give me 2 receptors, or 1 enzyme, 1 receptor. Give me the classes. 5-alpha reductase, and what's another drug I can give? Alpha 1. Okay, good. Perfect. Okay, alpha 1 blockers. So that's that. It's non-neoplastic. You can give these drugs, they respond. If not, you do something called a TERP procedure, where you just basically go through the urethra. Sure. The 2 layers, it's here. So number 1 is, let's just get another image that's way better, is you can see this layer of basal cells. And then you have the second layer, which is, it's covered by the red. But, like, let me erase the red. Number 1, number 2. Yeah, exactly. You won't see the basal. Do you see the 2 layers? This is number 1, number 2. Okay. It's non-neoplastic, non-precancerous, happens, it's age-related changes that can happen. And that's pretty much all you need to know. Obstructive symptoms. Okay. Now you can see here what's wrong in this image. Okay. Big nuclei, high NC ratio, good. You're hinting, great. Basal cells are gone, perfect. Is it invading the basement membrane? Good. Okay, so this is high grade prostatic intraepithelial neoplasia. It's mostly not, but you can see some cells going through it, okay? Going through the basement membrane. Okay, usually it's not. Okay, usually the high grade intraepithelial lesions are intraepithelial, it's not going through the basement membrane. Okay, that's why it's called that. The basal cells, are no longer like this one. Okay, here you can see a clear layer of basal cells. Okay, here you can't really tell that there are basal cells. It's just mixture of cells. Okay, it's not one clear line of basal cells. Okay, okay. So this is high grade. It can later progress into this. Once it starts invading the basement membrane, does not look like the normal prostate anymore, causes this. What is this, guys? Prostate cancer, okay, or adenocarcinoma. Good. Now, give me a marker that I would use for prostate. A marker in serum. PSA. Okay, tell me now. If the PSA levels are above 10, what is this concerning of? Cancer. If it's below 10, not entirely normal, but it could be BPH. It is 4 is the cutoff, exactly. But if it's above 10, that's most likely cancer until proven other. You need to look into it. Okay. 4 to 10, it's not normal. Below 4 is normal. Okay. 4 to 10 could be in BPH and stuff. And yes, you need serial PSA levels. Okay. What is one screening test you can do other than PSA? Screening, DRE, digital rectal. You can do a digital rectal, you can see. Why? Where is the cancer most likely developing? The posterior zone, exactly. So the one where you feel when you're doing a DRE. So if you feel the prostate and you feel it as diffusely enlarged, no nodularity, what are you thinking of? BPH. If it's nodular, not diffusely enlarged, one area is enlarged, cancer. Good. I'm gonna throw this guys at you guys. If it's soft and boggy, what am I thinking of? Prostatitis. Excellent. Good. I'll explain this stuff later, okay, with the prostatitis when I get to the micro section. Okay? Good. Okay, that's it for prostate. Now we're gonna go into the renal and bladder cancers. First one is this cancer, or not cancer, tumor. What is this tumor? Good. Perfect. Angiomyolipoma. Okay. Why is it called angiomyolipoma? Three different things you need to look into. Blood vessels, smooth muscles, which are striations. If you see any striations like this, you can tell that this is a smooth muscle, even here a bit. Okay, and then fat, which are these droplets. Angiomyolipoma. The most important high yield fact about this is what syndrome or tumor syndrome is this associated with? Tuberous sclerosis. If you remember tuberous sclerosis, most likely will present with epilepsy, with with a cerebellar mass, with angiomyolipoma. That's it. Tuberous sclerosis. Okay. Epilepsy, skin lesions, such as, for example, actually, I don't think you need to remember it. So, two skin lesions, epilepsy, seizures, angiomyolipoma, tuberous sclerosis. Okay. That's it. Yeah. But in this case, in the kidney, it's not actually showing sclerosis. Okay. Elsewhere. Okay. This is benign. Yeah. But the bad thing about it is it's part of a syndrome. Okay. Yikes. I did not realize this image had the name. But anyways, oncocytoma. Okay. How do I know this is oncocytoma? Give me the key thing you look on morphology. Central stellate scar. That's it, the white scar. Once you see or hear this white scar, I know this is renal oncocytoma. Okay. Central stellate scar. Now, here, most important thing, you can see this abundance of this pink amorphous material. This is what's causing this scar. You guys already jumped ahead. Okay. Why is it very eosinophilic? Because firstly, it's because of the mitochondria. That's why it's granular. There's an electron microscopy picture that has abundance of mitochondria. That's important to remember for oncocytoma. This is a benign tumor. Okay. Clear for oncocytoma? Mashallah, you guys are jumping. Okay. I don't recall, not gonna lie. Now this one. Okay, good. Renal cell carcinoma. Perfect. Now, renal cell carcinoma, let's talk about this. So, can someone tell me the triad in renal cell carcinoma? What's the three things that happens in renal cell carcinoma? Three presenting features. Hematuria, palpable mass, and flank pain. Perfect. What the hematuria is painless hematuria. Perfect, good. Now, the renal cell carcinoma, there's multiple types. The most common and important type is a clear cell one. Now, it's mostly, there are sporadic causes and heritable causes. Okay? I don't think you need to remember that specific detail, but I want you to tell me this one important heritable causes of renal cell carcinoma, which is what syndrome? Von Hippel-Lindau syndrome, VHL syndrome. Perfect, good. Okay, VHL. Renal cell carcinoma, can it cause paraneoplastic syndrome? Mutation met, perfect. Yes. What paraneoplastic syndromes can it cause? Cushing's, good. Anemia, polycythemia, okay? Polycythemia, not anemia, because erythropoietin, okay? And hypercalcemia, because of PTHRB, good. So these are the paraneoplastic. Now, in terms of morphology, is this big yellow mass, and this is in the inferior pole of the kidney, okay? So that's inferior middle pole as well of the kidney. Anyways, what type of renal cell carcinoma is this? Clear cell, okay? This is clear cell, and what is this one? Papillary. That's the two morphologies that you need to remember. In the papillary, very important, what are these? Some homobodies, guys, some homobodies, okay? Good. So clear cell, from the name, they are clear cells, white cells, okay? Clear cells, done, okay? Easy to tell. Clear white cells. Here, papillary, which are finger-like projections with a fibrovascular core with these calcifications, which are some homobodies. That's the histological findings. You guys already mentioned the features. You guys already mentioned the tumor syndrome that can be in, mutations in MET, and you guys told me the paraneoplastic syndromes, and you guys already told me the two histological classifications. That's it for renal cell. It's the most important tumor here. Okay. Cancers that, okay, in the kidney, renal cell carcinoma. Okay. Testes, seminoma. That's it. Okay. These are the tumors that are yellow in color, yellow-white color. Okay. Cool. Yeah. Yeah, right. Now, this one, guys. Transitional cell. Now, this one is located in the renal pelvis, where you have the calyces. Okay, so this is transitional cell carcinoma. Okay, urothelial cell carcinoma. Urothelial cell carcinoma is the most common type of cancer that happens in the urinary tract. Okay, most likely in the bladder. Okay. Now, I'm gonna test you guys on what things to look at when you're looking into urothelial cell cancer. The risk factors are so important, and we'll get to it in the upcoming slides. Most important thing to remember about transitional cell carcinoma in the kidney is it's located in the pelvis, okay? And in the calyces, renal pelvis and the calyces. Why? Because it's lined by transitional cells. That's it. Now we go into it. What's this tumor? It's the same exact one. But this one is in the bladder. So we call it urothelial cell carcinoma. So the bladder, I mentioned to you guys already. You have three types of cancers that can happen in the bladder. Number one, which is the most common, most important, is urothelial cell carcinoma. Okay. Number two is what? Squamous cell carcinoma. That happens due to squamous metaplasia. Okay. You need squamous metaplasia. You don't have squamous cells in the bladder. So you need something to happen. We'll get to what can cause this. Number three, which is rare, is adenocarcinoma. To repeat, what are the two important things that can cause adenocarcinoma? Urachal cyst. What's the other one? Extrophy. Good. Not patent urachus. Patent does, there's not that increased chance. Okay. Now, Urothelial cell carcinoma, most common type. You have the one that is fungating outwards and the flat one. Which one is worse, fungating or flat? Just a throwaway thing. The flat one is worse. And it's most likely in situ version. And why is it worse? Just a fun fact for you guys is when you're investigating these patients who present with like hematuria, you do a cystoscopy, you look inside, and you're not going to actually see the tumor if it's flat, okay? And it invades vertically, like into the walls, so it invades quicker as well. That's why it's worse, okay? That's the two reasons why it's worse. So now, urothelial cell carcinoma. What's the important risk factor? Most important risk factor. I want one, okay, perfect. Smoking. Okay, smoking is the most important risk factor. What are other risk factors, guys? Let's just say someone, exactly. I was literally about to say this. Someone working in a factory, leather, factory, drugs can cause it, good. Can someone tell me what the chemotherapy is called? Naphthylamine. I think so. Is what the word was. Cyclophosphamide. Okay. Cyclophosphamide can cause it. Good. Now, that's the important thing you need to remember is the risk factors. Now, for morphology, these cells over here, what can I say? These cells were necrotic. Okay, they're dead cells. It's highly proliferative tumor, necrotic, so on. Now, if I say I have squamous cell carcinoma, what's an important risk factor for squamous cell carcinoma? Schistosoma. Okay, schistosomiasis, which happens in what demographics? Good, more broad Middle East. طيب. Mostly it's Egypt, but more broadly it's Middle East. Okay, so Middle Eastern presents you with hematuria, had long-standing infection. You do imaging, you'll see a finding that we'll get to later, and then he presents with urothelial cell carcinoma. You look inside, sorry, not urothelial, sorry, squamous cell carcinoma. Okay, that's it. Now, guys, we are done with pathology. Any questions before we get? I have two slides for clinical, which is very important. Then we go into micro and radiology. Any questions for pathology? Yeah, this is painless hematuria. Cancers typically will cause painless hematuria. Okay, cancers generally. Okay, gross in general, yeah, gross painless hematuria, cancers. Think cancers. Okay, stones can cause hematuria, but they're painful. And the triad specifically for renal cell carcinoma is again painless hematuria. It's a characteristic plus the other two findings. So it's not just painless hematuria. It's not specific. If you have painless hematuria, it could be a cancer all throughout. Okay. You have the flank pain and the palpable or the visible mass. Okay. Palpable mass. That's a triad for renal cell. Okay. Yeah, generally painless hematuria, you're looking for cancer. If I have let's just give you a case. If I have a young male who presented with severe flank pain that radiates from the loin to the groin and has visible painful hematuria, what is this? Stone. Okay, you're gonna think of stone. Okay, that's why, because stone causes obstruction, urine backflows, distends the kidney, causes the pain. Here with these tumors, they're most likely growing and just not causing any pain. Okay, you have bleeding that happens, and that's it. For the stone, from the irritation of the ureters, for example, most likely your location. Okay, yeah, that's very important. Perfect. Thank you for mentioning this. Now, I'm gonna quiz the rest of you on this. So renal cell carcinoma, if it's on the left side, it can cause varicocele. Why on the left side only? Just tell me the reason. The testicular vein. The testicular vein on the left side will go to the renal vein, which can be obstructed, then to the inferior vena cava. Where is inferior vena cava? It's on the right side. The testicular vein on the right side drains directly to the inferior vena cava. Okay? On the left side, the renal cell carcinoma or renal tumors can block or can spread directly to the renal veins, the left renal vein, that will cause a left-sided varicocele. So just to repeat, left testicular vein goes to the left renal vein, though it then goes to the IVC. Right testicular vein goes directly to the IVC. Okay? So, any other questions, guys? Okay. Now, for these, what's the first? What are these in general first, guys? In general, what are these casts? Good. Now, there are multiple casts to remember. I don't know if you guys will be tested on this. Not gonna lie, I heard doctor said I'm not gonna test you on this. Then the doctor said I will test you on this. In the past, we were tested on this, so I brought this in case. And I need you guys to be very, very perfectly sure about these casts. The first cast is what cast? What's the color? Red. So what do you think this is? RBC cast. Where do you see RBC casts? What specific disease you see RBC casts? Nephritic syndrome. Good. So with hematuria, you have RBC casts. Okay. The most important cause for this is nephritic syndrome. So you need to just remember nephritic syndrome. This one is very important. What's this cast? Granular cast. Perfect. Which disease do I see granular casts? ATN, acute tubular necrosis. Perfect. Good. Whoops. The bottom picture, what is it? WBC casts. Now, WBC casts are non-specific. You might see it in, for example, tubular interstitial nephritis, acute interstitial nephritis. It's not a pyelonephritis. It's not specific. Okay, it's just WBCs. It shows you that there is inflammation. Okay. Now, if I tell you that when I did my urinalysis, I saw eosinophils, what important disease am I talking about? Eosinophils. Okay. This is something called acute interstitial nephritis or tubulointerstitial nephritis. No, they are not the same. Acute tubular necrosis is not the same as acute interstitial nephritis or tubulointerstitial nephritis. Acute interstitial nephritis is caused by, it's a hypersensitivity reaction. That's why you have eosinophils. Okay. In acute tubular necrosis, you have direct damage by this drug that causes damage to the tubules directly. Eosinophils in the urine. It's a very, very key finding. Acute interstitial nephritis is caused by drugs. And there's many drugs that can cause this. Diuretics can cause this. NSAIDs can cause this. What's it called? Proton pump inhibitors can cause this. So on and so forth. Okay? Many drugs can cause this. The most important thing to remember, guys, because I saw it in the slide in one of the clinical, yes, it's type 1, is that it is I think it is, yeah. Acute interstitial nephritis, most important finding, you will get this in the question, is eosinophils in the urine. And the person took drugs. Two important findings. Okay? Acute interstitial nephritis. I don't think this will come, but you have been warned in case. Okay. Because the clinical doctor who taught you guys is new, so I don't know what style of questions. Like one of them who gave you like renal stones, renal chemistry. New doctor, never taught before, so you never know what type of questions. Other than Danny Rabah, Dr. Danny, Dr. Noura, I think is their name. Anyways, whoever taught those, it was one of the slides there, I believe. So just in case, okay? Now you know. Yes. ATN, granular. Tubular interstitial nephritis, WBCs, more specifically, eosinophils. Good? Okay. Now, guys, stones. Again, I don't know if this will come, but just to be safe, because we were tested on this previously. So I want you guys to be good on these. Okay? The first one, this one. What type of stone is this, guys? Calcium oxalate. Perfect. Good. What's the most common cause of stones typically, or what type of stones are the most common? Calcium oxalate stones. Okay, that's the most common, and you have multiple risk factors for it. You have idiopathic, it can be caused because of very severe dehydration. For example, you're not drinking a lot, calcium accumulates. One important thing, alcoholic can cause it. Yeah, and then Crohn's disease can cause it because of oxalate. Okay, just some causes to remember. Most important thing for you guys to remember is for these calcium oxalate stones is the type of crystal, which is this. It looks like a coffin lid. Okay, what you put over the coffin, يعني غطا فوقها, that's the coffin lid. Okay, it looks like the top of the coffin. That's it. That's why they called it coffin lid appearance. Okay, that's calcium oxalate stones. This one over here, what type of stone is this? I think you are right. This might be the, yeah, I'm gonna take back that. This is envelope shaped. Good. Good job for reminding me. Yes. This is the envelope shape. It looks like an envelope. Okay. I thought of it as 3D, but this one is more clear. Okay. And it's more rhomboid shape, this one. This one is the coffin lid one, which is what type of stone? Staghorn. Caused by, I don't know why these animations are doing me like this. Anyways, what type of organism can cause staghorn? Proteus. Good. Okay, so this one is the coffin lid, staghorn, Proteus. Calcium is the envelope shaped. Good. Now, what are these stones right here? Hexagonal. Cystine. Perfect. Good. Cystine stones. So cystine, it's not that common that you have cystine stones. Uh, uh, it's not that common. You have it in a condition called cystinuria. Okay. Cystinuria is basically when you have failure of absorption, reabsorption of amino acids. Most commonly is cysteine. It's hereditary, good, and it fails to be reabsorbed, so it accumulates in the urine and causes cysteine stones. That's it. You have other amino acids. There's a mnemonic for it called COL. Okay, cysteine, ornithine, arginine, lysine. Okay, these are the four amino acids. Most important thing is cysteine, and it's this hexagonal appearance. Okay, that's it. The last one is this shape caused by what, guys? Soda, yes, to answer your question. Uric acid stone happens mostly with gout. Tom, good on crystals, guys? Okay. Just in case, if it comes, now you guys know. Okay, memorize these by heart. Now, there are other casts I didn't bring. So, for example, there's something called fatty casts, which are in nephrotic syndrome, epithelial casts, which is in ATN. But you don't have to identify it. The most important ones you identify are RBC, WBC, and granular. Granular is the most high yield one. Okay, that's it. Any questions for all that I discussed so far? Anything that's unclear? Mm, to a degree. If you have suspicion, for example, if you have someone who has illegal urea and everything, and he underwent surgery or hypovolemia and he has high lean casts, it's not going to be normal in that case. It's abundant. So to a limit, yes. Yeah, they're normally produced. Exactly. That's the whole point. It's normally produced. However, if you have an abundance with a suspicion of ATN, no. Okay, now it's supporting your suspicion of ATN. The TAM horsefall proteins are normally produced. It's just the time it's blocked that's causing these casts. Okay. Now for radiology. Now radiology, in my opinion, is the more difficult part of OSPE, at least for me. Personally, I didn't study it properly and kind of bit me badly in the exam. So I'm gonna make sure none of you repeat that mistake. Okay. So I'll tell you which images are high yield and you must know. Okay. Okay. So we're gonna get into it. Okay. So the first one, this. What is this disease? Stone. Good. Stone. Okay. Kidney stone. No. What is the first modality you can do for kidney stones? First modality. First. Not the gold standard. Multiple answers. What's the safest one? Ultrasound. You can start with ultrasound. Okay. Start with ultrasound. You can do kidney X-ray. Well, what's the problem with X-rays with kidney stones or stones in general? Some of them doesn't show. Some of them are radio opaque. Some of them are radiolucent. The radio opaque one is, for example, the calcium oxalate. If someone has gout, hyperuricemia, presenting with a stone symptoms, you're not going to see the stone. Okay, you're not. So you can't visualize them. So it's preferred you don't do the X-ray. You can, but it's preferred not. You can start with ultrasound. You might see hydronephrosis if it's in the ureter, for example. Okay. You look into the kidney, or you can just see the stone. Now, if I'd start with the ultrasound and I see this stone, it's hyperechoic. What's behind it? Shadowing. That's an important sign in ultrasound. Okay, is the posterior shadow. Okay. So that's on ultrasound. Most important gold standard is CT, because CT will detect all of them. It's not X-ray. CT. Okay. Non-contrast or contrast CT? Non-contrast CT. Non. Okay. When do you do with contrast for kidneys? Tumor is good. Renal cell carcinoma. You do it with contrast. Why is you want to see the washout. If you guys remember from radiology, even the crash course I gave last year, is when you give it a contrast, first you see in the aorta, it'll be very bright, and it'll go into the veins or the tumor itself, then the veins, right? So when you see these phases, you suspect tumor. Okay. In this case, it's preferred to not do see contrast because you want to see the whole thing. You want to see if it's, oh, it's hyper dense, for example, in this case, very hyper dense, looks like bone. Okay, this is calcified, this is a stone. So that's why you do non-contrast CT. Okay. First thing you can do is ultrasound. Later on, you can't see anything, or you see hydronephrosis, you want to confirm where the thing where the stone is, you're suspecting stone, you do a non-contrast CT. Okay. So this is the most important thing for you guys to remember, is not when to use which modality, is to identify the thing. You identify the stone, ultrasound, hyperechoic with posterior shadowing. Here it's hyperdense. Okay, lesion. Good. Okay. Next one, guys. Tell me what you see. Where is good? Okay. Bladder wall calcification, most likely due to schistosoma. Okay, good. So what cancer can this person develop? Squamous cell carcinoma. Perfect, good. This is the bladder right here, and this is the calcification. Okay, that's it. Now, what does this person have? This is very high yield. Like you will be tested on this. Almost guaranteed. What's wrong with the kidneys? Infections. Pyelonephritis. Why is this pyelonephritis? You see striations. Striations are so important, guys. Pyelonephritis, striations. Oh, first thing you see, if you see striations, pyelonephritis. Okay. You will get this in OSPE most likely. Okay. I'm telling you from now. You see striations, it looks like a zebra. Pattern, white areas, dark lines, white, dark. Striations, pyelonephritis. Okay. So that's how you can tell this is pyelonephritis on this imaging at CT. Similar finding you can see on ultrasound. It's not important. You need to identify it on CT. Okay, striations. Clear? Very important. Urothelial. Okay. The way you can think about it is cyclophosphamide causes hemorrhagic cystitis, can cause urothelial cell carcinoma. Okay. All right. So yeah, this one, pyelonephritis. Pyelonephritis, signs and symptoms, fever with flank pain. Very important. Fever, flank pain. You're suspecting pyelonephritis. It could be someone who previously had suprapubic pain, dysuria, had simple cystitis, and it ascended up, goes to pyelonephritis, okay, which is infection of the kidney. When you do imaging, you don't really have to do imaging, but if you do imaging, you find striations, pyelonephritis. Cool. The way you actually confirm it is do a urine analysis and everything. You see all these signs. Okay. But here you can see striations. Very important. Now, to let's just say someone who had pyelonephritis developed a complication of pyelonephritis, which is this. What do I see here in the kidney? In the kidney, abscess. Okay, fluid accumulation, abscess formation. So this is a intrarenal abscess. What if it's around the kidney? Not clear in this image, but imagine it's around the kidney. It's not in it. Perinephric abscess. Okay. Renal abscess and then perinephric abscess. These are abscesses. Just know how you can tell this is an abscess. If you do, for example, with contrast, it won't show you the triphasic. Okay. This one. Yeah, you can't tell where the kidney is, like properly, but perinephric is going to be around the kidney, within the capsule. Okay, in this image, it's not really that clear, not gonna lie. Here, you can clearly tell it's inside the kidney. Okay, so that's complication. Now, there are two types of pyelonephritis, you could say, that you can tell on imaging. I just want you guys to know identification. You see this, immediately put it and never look back again. Okay. I'll tell you at the end of the radiology section, if you want to revise radiology after this, what to look at in the slides. But I included majority of it. So this image, which showing black, good. Okay, emphysematous pyelonephritis. Okay, both, if you see black, think emphysema. So this is emphysematous pyelonephritis. Clear? The first thing you see is you see black, think emphysema, emphysematous. That's it. Okay. If it's testing you on the different types of pyelonephritis, if you don't see air, you go for the next one, which is this one. Which is, yeah. If you don't see air, if you don't see these black lesions that looks like air pockets, you go for this one, and it looks complicated, which has hypodense, hyperdense areas. This is a stone, for example. This is xanthogranulomatous. This is the only thing I want you guys to know about this. Like, I have no idea, like, I'm not sure what this is, not gonna lie. So, yeah. So just know xanthogranulomatous, there's no air. Okay, pockets. This is the image that you most likely will get, this one. Okay, this is the most likely image you're gonna get. This thing, you can see the stone and large kidney. If they give you a case, had signs of pyelonephritis, you don't see air, you go for xanthogranulomatous. You see air, emphysematous. Okay, that's it about it. Nothing else here. Now this one. Medullary sponge. Okay. Medullary sponge kidney, as I said, multiple cysts in the medulla. If I tell you if I tell you a few cysts in the cortical medullary junction, what do I call this? Medullary cystic. Okay, good. Medullary sponge, many cysts in the medulla. Okay. And you can clearly tell, is the cortex involved here, even here? No. Okay, you can see that it branches from the major calces to the minor ones, and only involving the medulla. Okay, cortex is spared. Medullary sponge kidney. So now one by one. These are important high yield. Just know how to identify them. Okay, the first one. The kidney that's on, okay, good. The left kidney, is it normal? Yes. What's wrong with the right one? It's in the thoracic cage. Okay, it's in the chest. So this is what we call thoracic kidney. Just to briefly explain embryology, as you remember, you had pronephros, mesonephros, metanephros. The actual kidney is a metanephros. So it starts in the pelvis and ascends up. If it ascends too much, thoracic. If it ascends too less, pelvic. Clear? That's it. So now, let's skip this middle one and go to this one. What's wrong with this kidney? Pelvic. Okay, as I said, if it does not ascend, it's pelvic. If it ascends too much, thoracic. Okay, so that's it. What happens with this kidney? Or let me say kidneys. They fuse. This is cross fuse kidney. Okay, cross. They had to cross. The other kidney went to the other side, fused with it. Okay. Now, what if the inferior poles of the kidneys fused? What is this? This is the most high yield out of all of them. Horseshoe kidney. Um, why is it fused? What's the artery that's blocking it, guys? Inferior mesenteric artery. Perfect. Good. Okay, inferior mesenteric. Okay, it's here. It's not letting it go up, so it fuses in the bottom. Okay, horseshoe kidney. Whatever I said, by the way, it's just a fun fact. If it gives it to you in the case, sometimes you see it in Robin's questions as well. It's that, like, which artery or something, you now know. Most important thing, you identify it. Horseshoe kidney. Okay. Clear with all of these? Okay. Now here, what's wrong with these kidneys? Give me good. This one, hydronephrosis. Perfect. How do you know hydronephrosis? It's big and large, and you have dilation of the calyces. Okay, major and minor calyces. That's number one. Why could it be hydronephrotic? Is stone. Exactly. Could. Most likely is a stone. Where is a stone? I'm gonna just test you on this. Where is a stone most likely? Perfect. Uretropelvic junction, most likely. Okay, good. So this is hydronephrosis. This one, what's wrong with this image? Double collecting system, good. So here, double collecting system, you can see, let's just talk about this kidney. This left kidney, you can see the calyces are fusing together and forming one output and then one ureter. Here, you can see that this major calyces, the upper one, superior, is forming its own ureter. The middle and inferior calyces are forming its own ureter, which is here. So this is what we call double collecting system or duplex system, okay? Duplex collecting system. Can you guys identify these clearly now? You need to know like these differences, okay? Because most likely, I'll tell you guys at the end. Now this one is kind of disgusting, okay? Disgusting in terms of there's stuff to memorize in this one. Well, you most likely will be tested. Yes. Wait, what do you mean by both? Yeah, basically, duplex means there's two or double. Okay, there's two ureters now. Okay, and you can clearly tell all the way. You can still see that there's two. Okay, that's basically the whole point of it. Okay, so this one is stuff to memorize, but most likely they'll give you something very simple, and it's in the next slide. Okay, these are, I wouldn't say simple cysts, but this is what is differentiating simple cysts from complex cysts, from a more benign cyst to something more dangerous looking, malignant features. Okay, so the most simple cyst is Bosniak 1. This is the Bosniak classification. If it's Bosniak 1, there is no septations at all. Okay, this means, okay, I'm dealing with a benign cyst. It's not really causing anything. I can leave it alone. Okay, that's what's important about this. This is a simple cyst. Bosniak 2 is still, it is more simple. However, it has this bad feature that we have, which is it has septations. It has few, less than 3 septations. Okay, less than 3. That's the number you need to look into, 3. So in this case over here, how many septations do I see here? In Bosniak 2? 1. Okay, so if it's 1 septation, I can say it's Bosniak 2. If it's 2 septation, Bosniak 2. If it's 3, Bosniak 2. If it's more than 3 septations, and the most important thing is also the size of this. If it's less than 2 millimeters in width, this is most likely Bosniak 2 or 2F. What's the difference between 2 or 2F is more than 3 septations. The size is the same, just more than 3. Okay, so here you have 1, 2, that's also dividing, 3, 4. Okay. Okay, so that's the differences between Bosniak 2 and 2F. Bosniak, and most important thing is its narrow septa. Bosniak 3 is the septa are thick. Okay, once you start seeing thick septa, this is Bosniak 3. If these septas or these cysts have nodules, then this is what I call Bosniak 4. So to repeat, if I have no septations at all, what Bosniak classification do I give it? 1. If it has less than 3, the size is less than 2 millimeters. 2. If the size is less than 2 millimeters with more than 3, 2F. If the size is large, more than 4 millimeters, and thick septa. Thick septa. 3. If I see a nodule, 4. Does that make sense, guys? You just have to look and see it, okay? Very thick nodules. Okay? Now, in these images, you need to classify them. Okay? So you classify them 2 different ways. Wait 1 sec, guys. Okay. I'm trying not to get kicked out. Anyways, so you can see here is these two images. Most of these are two images you need. The first one, it doesn't appear to be septas. However, it's a bit thicker here, and then there might be one right here. It's very unclear. So what Bosniak feature do I see? And there's calcifications. This image is very bad. There's a septa. It's very unclear. Okay. 2. With calcification, 2. Okay. The amount of septations you might see is less than 3. There's calcification, 2. How about here? There's a calcification, and then there's one septa that's dividing into 2. 2. These are both Bosniak 2. This is the only image that's available. Okay. Remember Bosniak 2. If you see a nodule, clear calcified nodule, Bosniak 4. Okay. Very thick nodule, Bosniak 3. Nothing at all, Bosniak 1. Okay. That's how you classify them. Now, here. What is this, guys? Okay. Guys, on CT, what color is fat? Black. If I see a nodule that's fully black or black areas, meaning that it has fat. What's the tumor that I told you guys that had fat in it and the guy has tuberous sclerosis? Angiomyolipoma. Okay. Renal angiomyolipoma. Okay. To tell the difference, okay, you might tell me how is this not emphysematous pyelonephritis? Signs and symptoms. This is the kidney. Wait. Oh, sorry, I'm using eraser. This is the kidney. This is the kidney. This. Okay. You can see this one is fully black. So angiomyolipoma. Hypodense lesion. Okay, because it's fat. Here it's the same thing. And you can tell the difference between signs and symptoms. This guy has skin features, epilepsy seizures, has this feature, angiomyolipoma. Okay. Why is it dark colored? Because it's fat. It has fat. Okay, but it also has other things with it, which is such as muscle. Okay, so that's why you have other types, other cells. So this is a more hyperdense compared to the darker areas, which is black. Does this make sense, guys? Yeah, this one most likely does not have contrast because I look at the aorta. Look at the aorta. It's very similar to the surrounding structures. If it's very, very white aorta, then I can tell that they use contrast. The reference is aorta. Clinical context, you'll get it with signs and symptoms of, like, you'll see other signs of tuberous sclerosis. This guy had epilepsy and everything, they give you this. And you can tell, okay, this is angiomyolipoma. In another clinical context, if they have no tuberous sclerosis, painless hematuria, flank pain with a palpable abdominal mass, you think of RCC, you do CT with contrast. And you can see a very big tumor. It's much larger than this. Very large tumor. Okay? That's how you can differentiate these tumors. Most important thing is you see these black areas, you think of fat. Okay? Now, this one is important as well. You'll get it in MCQ. Like we got it. And I didn't like this question, not gonna lie at all. Okay? So the most important thing is you know the extent of the bleeding. Okay, so this is renal trauma. And this is the bleeding that happens with renal trauma. Grade 1, the bleeding is only in the capsule, so it's subcapsular. It's barely extending into the cortex. Okay, so that's grade 1. If it starts to extend into the cortex less than 1 centimeter, this is grade 2. More than 1 centimeter, grade 3. Starts to go into the Medulla, grade 4. And then if it's completely shattered kidney, 5. So I'm going to test you guys. 1, it's only in the capsule. What grade? 1. Completely shattered kidney, what grade? 5. Goes all the way through the cortex into the medulla. What grade? 4. If it's invades through the cortex, less than 1 centimeter to more than 1 centimeter, 3. Okay. Does this make sense, guys? Yeah. It's just straight memorization. Now, this thing. Now, this guy, testicular mass. Okay. You do ultrasound with what? Ultrasound with what in these 2 images? What did I use with the ultrasound? Doppler. Good. So this is ultrasound with Doppler of the testes. This guy, this with the yellow arrow, I just tell you, had fever or has a fever. What do I say? And there's no color on Doppler. So what could this be? Mass filled with no testes. Abscess. Okay. So testicular abscess. So testicular abscess. Okay, good. If it has blood, what am I suspecting? Blood is very important. Tumor. Okay, tumor. Does not matter what type of tumor, blood equals tumor. Okay, for ultrasound with Doppler. That's it for radiology. Now, I want to tell you guys. For radiology, there are a lot more slides, like so many slides. Anything that has red is important for your exam. Anything, whether it's a red question mark, red text, something with red is important for your exam. I included majority of them. However, I might have missed some. I tried my best to not miss anything, and I brought you guys the most important ones for your exam. Do you guys have any questions for radiology? And you want me to repeat anything? Or is everything clear? Let me know. The imaging? Like open it up and go over it for you? Yeah, I don't mind. But it's not as important, prostate imaging. Imaging like CT, ultrasound, all of these. Oh, okay. Yeah, I'll try. After recording. Okay. Any other questions like from this? Okay. Now micro is very short, very easy in this block. I only have a few slides. Imaging wise, for micro, I bought a few. Okay. Uh, it's very simple micro in this block, so don't worry. Okay. So let's start. Firstly, female, young, had had suprapubic pain, dysuria. What are you suspecting? Suprapubic pain with dysuria. UTI, where? Bladder, so what I call it, cystitis. Good. Okay. What's the most common organism? And you see it here. E. coli. Good. Now let's just tell you that if I have the same female who is sexually active, what's another common? Saprophyticus. Good. Okay. And causes of STI as well. Okay. That's also important to remember because they're very, very like together. Okay. So you're also right. Okay, think of STIs such as gonorrhea and such as chlamydia. Okay, also. But saprophyticus is something that causes directly UTI in young sexually active females. Gram-positive cocci. Okay. E. coli, gram-negative rod. Now, what are some lab investigations in urinalysis that I do for a UTI? For UTI. Nitrites, good. Nitrites tells you what? Presence of bacteria. Perfect. Nitrites shows you that there is bacteria. What's another enzyme? Alkaline. Yep, nice. Leucos leukocyte esterase. All right. Perfect. Okay. So leukocyte esterase tells you that there is pyuria. There's WBCs. Good. Okay, so that's the two things. Leukocyte esterase, nitrites. Nitrites tell you bacteriuria. There's presence of bacteria. Leukocyte esterase tells you there is pyuria, pus or WBCs. Okay, so these are the two workups. You can do WBCs, you can do all these other things as well. Okay, these two are important when you're looking for a UTI. Okay, so E. coli, give me one important virulence factor that's why it causes UTIs. Important virulence factor for E. coli. Other than capsule, think Fimbria. Good. Fimbria. Why? It's in urine. It needs to, swim. Okay. So you need those Fimbria for it to go on to the bladder and go over. Fimbria are like one of the more important ones. Now for E. coli as well. Is it a lactose fermenter? Yes or no? Yes, good. Indole. Is it indole positive or negative? Yeah, it's the reason why I told you this is we got this in our exam last year. It's indole positive. I'm gonna type this in chat. Okay. INDOLE. Okay, it's indole positive. We got a question that had this, and that was the only differentiating point in the question to tell the difference between organisms. Okay, so I'm telling you, indole positive. Okay, you got that from me. So lactose fermenter, indole positive, these are just signs you might get in the question stem. Okay, so that's what we got last year. So that's it for E. coli. This organism. Proteus, good. What's this pattern called? Swarming pattern, perfect, good. Now, very important is it urease positive or negative? Positive, perfect. That's the most important one. Is it gram negative or positive? Negative, perfect, good. Okay, that's it for Proteus. What is this? Schistosoma, perfect. What type of schistosoma? Hematobium, good. Now schistosoma hematobium is in the bladder. There's also other two types, which is Mansoni and Japonicum, which is mostly in the biliary and the mesenteric vessels and so on. So don't worry about those. This one is hematuria. What's a very important host or the other organism, or not the organism, the other, yeah, freshwater snail. There we go, you got it. Yeah, that's the important thing about it is snail. It's associated with snails. Good. And it has a large terminal spine. Okay, large terminal spine. Now, this one is for prostatitis. Now, for prostatitis, you have acute chronic prostatitis. Okay. Now, this first one, now when you do your analysis and you get urine culture and urine samples, you have to request the patient do specific things. The first thing is this: what's the first image? Where is the urine coming from? Tell me, where is it coming from? Where in the whole tract? Urethra. Will this help you in prostatitis? No. Good. It won't because it's from the urethra. So this might be important urethritis. This might be important, for example, if someone has STI causing urethritis, such as gonorrhea, chlamydia, stuff like that. Yes, it'll be helpful. In prostatitis, that's not the important one. However, this one, this is what we call midstream, which is getting it from the bladder. So it gets it from the bladder, takes the prostatic secretions with it. So you will get it for the prostate. This is what you need for prostatitis, okay? And for UTI. Perfect. Now, what are you doing in this third image? What are you doing? Prostatic massage. Now, I'll give you this case. If I have a patient with acute prostatitis, should I do this? No. Okay, no, you do not. Why don't you? Two reasons. Seething, painful, perfect, good. Seething and very painful, so you don't do this in acute prostatitis. Then, after you massage the prostate, all the secretions goes into you stimulate the prostate, produce all the secretions, pushes all the secretions into the urethra, and then you do the voiding and you get the secretions with it. Now, in acute prostatitis, which one of these? 1, 2, 3, 4 do I depend on in acute prostatitis? Acute. Why 4? That's post-massage. You do it for 2. Why would, like in acute prostatitis, you don't do massage? So you depend on 2. And chronic prostatitis, which one? 3 or 4, okay? Most likely 4 because this one is just you stimulate the prostate, then you ask them to void. So it's most likely 4. 3 is never the answer, okay? That's why like you need to void and get all the things out, then you assess, okay? So it's 4. Clear? Why you don't do 3 for acute prostatitis? Good. And that's it. Another thing for micro is try to know the how to take samples. Okay, the cup for the sample. That's also very important. Okay, but that's about it. Okay, any questions? All good?
Thank you, Fawaz. Really, you always come through.
No problem. Okay, anytime, guys. If you have any questions, my contact is in the beginning of the whole course. Text me if you need anything. Okay, best of luck, guys, inshallah.